So I'm gonna introduce our last speaker, my friend, my partner, my brother, Dr. Carlos Lehn. We did together almost 100 cases, and tomorrow we're gonna have 2 microwave cases in our clinic. And Carlos Lehn is the director of head and neck surgery service at the Hospital do Servidor Público Estadual, and he's a huge experience in tumors of head and neck and large tumors. And nowadays he loves ablation. He loves ultrasound, he loves ablation, and he talks all the time about this. So Carlos, thank you to have you here with us, and let's start.
Thank you very much, Fernando. First, I'd like to thank CCMA and the SBCCP and the ECHO for inviting me for this very, very interesting, and I have a pleasure to have my partner, my friend in life and in profession, and another friend, Rivelto. We know each other for almost 30 years, and it's a pleasure to have them along with Dr. Bulent that I am following for some time now. Well, let me put the presentation in white screen. Everybody can see it? Okay. Well, my subject of presentation are the differences between microwave ablation and radiofrequency ablation in thyroid nodules. Now I'm in trouble. I'm squeezed between 2 great presentations, one from a radiologist, very skilled in microwave ablation, and another with a very skilled head and neck surgeon fellow of us in radiofrequency ablation. Then I will try to elevate the level of my presentation to go along with you. First, we need to know that thyroid's ultrasound prescriptions are rising all around the world in the last 10 years. Most about clinicians, gynecologists, general practitioners, and most of them, unfortunately, with lack of accurate indications. Then we are seeing every day more and more thyroid nodules being diagnosed. But we need to know about the behavior of these thyroid nodules. This article is very interesting, but because it shows that most of these nodules, at least 75%, will remain stable along the years. A percentage of them will shrink about 13% according to this casuistic, but 11% of these thyroid nodules, benign nodules, will grow along the time. And this concerns us because even it's only 11%, it's 11% of a great number of diagnosed numbers. Then nodules. Then we will have a lot of nodules to be treated. This is the Dr. Rivelto and Dr. Bulent already showed this. This is the mechanism of interaction between water molecules and the microwave. The microwave excited the water molecules, increasing the temperature of the tissue, and then leads to necrosis of the tissue, of the nodule, or the tissue that we are treating, to apoptosis. Then we have here, Dr. Rivelto already shown this, the differences between microwave that generates a larger heat zone with direct heating and thermal conductance, larger than the radiofrequency ablation. Well, here we have both techniques presented in this graphic. The larger area of ablation of microwave device comparing with radiofrequency device. In the first periods, the antennas, and here you have to point this, we call this an electrode for radiofrequency ablation, and the term used for the instrument of microwave ablation is the antenna, because it conduces the microwaves through the tissue. The area is larger, and in the first antennas, it was not cooled equipment without saline, and the heat sink effect was larger, and the technique must be the overlapping technique like Dr. Bullet already shown us. Well, we have always to remember and to use the anatomy knowledge for every procedure, since it's surgery or not surgery, invasive or not invasive procedures. And in thyroid, we have these 2 points that were very, very exhaustively explained by Dr. Bullet, the vagus nerve and the dangerous triangle that contains the recurrent laryngeal nerve. These 2 zones need to be very carefully treated when we are approaching a benign thyroid node. Then the correct indication, the correct patient selection. Not every patient could be a candidate for microwave or radiofrequency ablation. The patient could be an ideal nodule like this one, but could be a patient with a shorter neck or a larger neck or a very anxious patient. And then in all patients, I performed in our office, me and Fernando, we performed previously to the indication of the technique, a simulation with the patient in that position, with the compression of the ultrasound transducer, and the simulation of a needle inside the neck of the patient to see if this patient are prepared for this procedure, because we do not use general anesthesia. You use only local anesthesia and a mild sedation. We have to know the method limitations, and we have, as Dr. Erivelto has shown, the adequate follow-up to see our own results and see what we are doing. I selected some articles from the literature to show you the results, since this technique is very new in Brazil. It's only authorized by Anvisa in Brazil in last November or December, and we have few cases performed nowadays. This randomized prospective, non-randomized prospective multicenter trial comparing RFA and microwave ablation with more than 600 patients each group, with a very comparable groups of patients, shows us these results. At the end of the follow-up, at 12 months, we have 89% volume reduction rate for their radiofrequency ablation, and about 82% for microwave ablation, with a slightly higher percentage of complications for microwave group. But we need to emphasize that most of these cases were performed with non-cooled antennas at the first times. Then it changed in the last few years. This other study from Verlander, with 60 patients and 65 nodules treated with RFA and microwave ablation, we using at that time the multiple overlapping shots with nodules with comparable volumes and comparable energy delivered, and even slightly lower time of ablation for microwave equipment, shows us no significant differences in 3 months VRR, 51% for RFA and 43% with microwave, with the number of shots quite different for microwave. Only 3 shots mean for the completion of the ablation. And heat sensation and was the most complaint of the patients, and 1 patient with temporary Horner's syndrome in microwave ablation case. And the conclusions of the authors that the similar results in terms of energy and VRR for the nodules for both techniques, less shots in microwave ablation for the same result, and greater risk of thermic injuries in microwave group because it was performed with non-cooled antennas. That is not our reality now nowadays. This another study is the systematic review and meta-analysis and comprising more than 800 patients in each group of microwave and radio frequency ablation, with only 5 studies selected after the removal of the exclusions of the review, shows us very good results for both techniques with a slight more volume reduction for microwave ablation in 12-month follow-up with no difference in complications. Here are the numbers of each study. And when we talk about large nodules with more than 3 centimeters in the larger diameter, benign nodules, this study treated 40 patients with most of them with higher cosmetic scores, complaints of the patients about this. This is the largest diameter of the nodules, the mean 40 centimeters, ranging from 3 to 65 centimeters, and a median range of volume of 22 cubic centimeters. Most of them were spongiform, isoechoic, and most of them, 70%, were treated with only 1 session of microwave ablation. 13 patients, 30% of the casuistic, needed two sessions that were delivered in a mean interval of 5 months, ranging from 2 to 15 months. Well, this is the curve of volume reduction rate, and we can see here that at the end of the follow-up of the study, 96.4% of volume reduction of the nodules. It's a very, very good, excellent result for large nodules in thyroid, benign nodules. And we can see here, as our colleagues already cited, the nodules with spongiform qualities or more cystic qualities have higher volume reduction rates. This is another study, very interesting, a comparative study of follow-up about the microwave ablation in visible nodules with different internal characteristics. The authors were interested about the intrinsic characteristics of the nodules. Well, here you can see the cosmetic score. The patients were not complaining anymore about his nodules. We can see here the results according to the kind of nodule: solid, simple nodules, mainly solid or mixed nodules, and mainly cystic nodules. And we can see here that for mainly cystic nodules, we have an 88% volume reduction rate. That's greater than for simple solid nodules and a little bit more effective than for mainly solid nodules or mixed nodules. And we can see as the results of this study, despite the number was not too high, that some morphological characteristics of the nodule seems to influence the success of the procedure and can be used as outcome predictors. If your patient have a mainly cystic nodule, you can predict that the result will be better than a totally solid nodules. But we have another issue that is very interesting. I will put it in more slides here because it concerns us all. In this study, in 89 totally cystic nodules in 69% patients treated with microwave ablation, the authors found 10.3% of intracystic bleeding during the procedure. Bigger nodules are most likely to bleed, and this intracystic bleeding enlarges the duration of the procedure, of course, and worsen the outcome of these patients. And the authors discuss how to prevent and how to manage this complication. This is a tricky complication because here you can see a totally cystic nodule with little vascularization in the periphery of the nodule. And here we can see the same nodule with large bleeding during the procedure. The authors matched the patients in two groups, bleeding group with 9 patients and control group with 11 patients, according to the characteristics more similar. And we have here the values of these characteristics. And the nodules with larger than 3.5 centimeters were more likely to bleed than the lesser nodules. Then, what the authors suggest to do if you have this kind of complication. First, stop the procedure, put like a compression for 3 to 5 minutes over the nodule, over the area of ablation. If after this time the bleeding stops, you can aspirate the rest of the blood and restart the ablation. But if the bleeding remains, you can put both the ablation antenna and an aspiration needle connected with a syringe of 22 cc, simultaneously ultrasound guided, aspirating the blood with the syringe and trying to reach the point of bleeding with the tip of the antenna to apply the ablation over the bleeding point, and paying attention for the other bleeding points that can appear near the capsule. The message is, when you have a large, sometimes hypertensive cystic nodule, when you put the antenna of ablation, you can lower the pressure and allow some vessels to bleed inside the nodule. Then, what's the consequences of this unavoided, unexpected, and serious complication? The operation time is very, very increasing, and the hospitalization, the need to stay in the hospital auments too. And the main consequence is that the result, the final result, is very, very worse compared with the control group with no bleeding. 83.8% of reduction after 12 months, against only 56%. It's above the 70% we expect in 12 months. And this is a very serious complication that can compromise the patient during the procedure. In some cases, you need to convert to an open surgery, and you have a worse result. Well, what we have about microwave ablation in the last consensus. This that Dr. Rivelto already shows us shows only the comparison of efficacy of techniques and cites only briefly the microwave ablation, because it's a new method. It starts with much less time than the radiofrequency ablation. And this other review of the American Association of Clinical Endocrinology only cite the thermal ablation with microwave among other thermal procedures. Please, could you close the microphone? Sorry, thank you. And they cite only 2 studies comparing RFA and microwave ablation, concluding they are both safe and effective techniques for ablation for benign thyroid nodules, but seems that radiofrequency ablation, in the opinion of these 2 studies, produce a higher long-term reduction in terms of nodule volume. And for thyroid microcarcinoma, papillary microcarcinoma, the microwave ablation has proven its ability to achieve complete remission in almost 94% of the cases. These are the only citations of this technique because it's very new. So, summarizing, the main differences between the both methods are listed here, in my opinion. The source of energy, it's my electromagnetic energy for microwave ablation, electric current for radiofrequency ablation that leads to some impairments. For example, patients with pacemakers, pregnant patients are not eligible for this kind of procedure. In microwave ablations, it's obvious we don't need grounding pads. We can achieve higher temperatures in internodal tissue. Its feasibility in large nodules is better, with better results for microwave comparing to RFA that sometimes needs more than one session for larger nodes. The time for ablation is shorter, and the heat sink effect is lower, as Dr. Erivelto and Dr. Bullet already shows us. You can use the antenna of the microwave ablation for alternative pathways to ablate some lesions, like the lateral, the craniocaudal, that is not allowed with the radiofrequency ablation, that needs to be always transsystemic approach. Well, here we can see this table provided by ECHO that shows us we use generally lower outputs of energy. We start with 20 watts, sometimes 25 watts, depending on the size of the nodule, the position of the nodule. And we can see that's a relation, direct relation between the time you leave the antenna in the tissue and the energy delivered and the radius of ablation that will be greater and greater as the times passes. We have two gauges of the antenna, 16 and 17. We generally use the lesser one for thyroid cases when it's available. And we need to pay attention for these graphics because like our colleagues already have spoken, we don't have the feedback of the impedance like in radiofrequency ablation. We need to rely on our eyes, seeing the hyperechogenicity of the ablated area and take in mind this kind of effect. The longer the time you leave the antenna active in a portion of tissue, the wider the area of ablation. But we can achieve higher temperatures without carbonization with this technique. Here you have two examples. This was our first case that me and Fernando performed in December last year. It was the first microwave ablation of thyroid nodule performed in Brazil. It was a patient of 60 years old with a huge nodule, a complex nodule with cystic and solid areas, totally benign after 2 fine needle aspirations. This patient comes to us even with a computed tomography showing the nodule, it's visible in the neck, and it has 42 cubic centimeters. It's a very huge nodule. We treated him with microwave ablation. It was a 12-minute section of ablation with at least 20,000 and 1,500 watts. And 45 days, the patient needed to come to us in the 1 month after, but he was positive for COVID at that time, and he delayed his first ultrasound 15 days. Then we have this control 45 days after, with a significant reduction of the nodule, almost no symptoms, and the nodule had 15 millimeters at that time. And in the 3rd month of the follow-up, here you can see the nodule. It's still a complex nodule with areas of cystic and solid tissue. These cystic areas, Dr. Laila, that are accompanying us direct from Naples, help us in this procedure. The colloid is too thick, it couldn't be aspirated. There was no really cystic and fluids area, despite the tentatives to aspirate this. But we are very happy with the results. The nodule starts with 42 ml. Nowadays, it's with 7.04 ml, with a reduction rate of 83% in 3 months. And this is another case. It's Fernando's patients performed by him. It's a much more newer case. It's a very huge nodule with 4.2 centimeters in the largest diameter. It was a very thin patient with a visible nodule in the neck, with a huge volume of 23 cubic centimeters. And in the first control, 45 days post-ablation, it was the same with that patient. He tested positive for COVID and he needed to stay at her home for 2 weeks. And it delays our control 15 days. But we are very happy because we have a volume reduction rate in 45 days of 70%. And the patient without complaints of the nodule compressing and appearing in her neck. Thank you very much. This is the end of my presentation. I'd like to thank you all for the organization, for our colleagues. And this is my hospital, Hospital do Servidor Público de São Paulo. Here's our new center with a huge amphitheater. You are all invited to visit us and to share your experiences with us. Thank you very much.
Thank you.